series in stroke. It gives me immense pleasure to welcome our post director for today's session, who is Dr. N.R. Richaporia. Sir is the director of neurology at Sahyadri Hospital. He has set up the first neuro ICU and neurointensive care of Pune. He has been a pioneer in thrombolysis treatment for stroke and has been a member of ISA and organizing president of Strokeathon. He is the founder of the Pune Stroke Group and the ex-president of Society of Neurosciences. Sir has been principal investigator for multiple multinational stroke trials and has been awarded as a health icon by the Times of India Group. We welcome you, sir. Thank you for being on board.
Thank you. Thank you.
Today we have Dr. Dinesh Kabra as a moderator. Sir is the consultant neurologist and stroke specialist at SIMS. His area of expertise include acute stroke management and stroke prevention. He has credit of publications and researches on inflammatory cytokines and hematological parameters in ischemic stroke, and he has the credit of publications in various national and international journals. He has also contributed with the help of abstracts at global conferences, include the World Stroke Conference and the AAN. Sir is a member of the Indian Academy of Neurology, American Academy of Neurology, and the Indian Stroke Association. We welcome you, sir. Thank you for being on board.
Thank you for very kind words.
The second moderator for today's session is Dr. Sunil Gajre. Sir is neurologist at the Gajre Hospital in Jalgaon. Sir is the fellow of the Royal Medicine from London, member of American Academy of Neurology, and he has credit of attending multiple national and international conferences. He has published data on research topics like herpes simplex, encephalitis, chikungunya, and Guillain-Barré virus. He has written multiple articles on epilepsy management. We welcome you, sir.
Dr. Sunil, are you there? I think he hasn't joined.
Yes.
Okay, let's introduce the speakers.
We have two eminent speakers with us today, Dr. Aswathi, and she is associate professor in the Department of Neurology at MES Medical College. Ma'am is being awarded as the best for the best paper at KUHS National Conference and has won the first prize in poster presentation at API Kerala and has multiple awards for research in stroke and metabolic syndrome. She has credit of publications in various national and international journals. And when it comes to presentations and teaching, she has presented at forums such as the Clinical Neurological Teaching Course and the Secrets of Neurology. Her research interests include stroke recurrence, microemboli detection via cranial Doppler, and various other expertise. We welcome you, ma'am. Thank you for being on board.
Welcome, madam. Good to have you on the group. Namrat, there's a lot of echo which is happening.
Okay. Is it better now?
Now, I don't know. You just said 3 words. So I don't know. Anyway, let's go on.
Our next speaker is Dr. Ahmed Subir. Sir is the consultant neurologist at the MES Medical College. And he has multiple achievements, including the Young Teacher of the Year Award in 2021, Young Investigator Award in the World Stroke Congress, then multiple awards for presentations and research at international conferences, including INCON. When it comes to leadership and membership, he is the vice chair and of the Vascular Neurology Committee and the member of esteemed organizations such as ISA, WSO. We welcome you, sir. Thank you for being on board.
Thank you very much. Good evening, everyone.
Good evening.
Good evening, sir.
With no further ado, I would like to hand over the session to Dr. Richaporia, sir.
Yeah. Thank you for the introduction of everyone. And it's a great pleasure to have all of you here. And we've had this program for the last 1.5 years or so, every month, month on month. And we've had some fantastic cases from all over India and a lot of learning for us. And I'm sure today will be equally good. And I really want to welcome Dr. Dinesh Kabra, who's an eminent stroke neurologist from Nagpur, and he's done a lot of work. And he's very passionate about stroke treatment and thrombolysis and the entire stroke management. And I'm very happy to see two very young and dashing neurologists, Dr. Aswati and Dr. Ahmad, and I'm sure they will add a lot of value to today's program. So let's start. And who's going first?
Dr. Ahmed, is that fine if you go first?
Dr. Ahmed, can you share your screen and proceed?
Oh, no problem, sir.
Yep. We are missing Dr. Gajre. I don't know where he is. But anyway, he's a good friend. He's from Jalgaon, and he's really established himself as a premier neurologist in North Maharashtra. And he's very active and very committed to furthering neurology and stroke neurology in his area. So we welcome him also. Dr. Ahmed, could you go ahead?
Yes, sir. Can you see the slide? Sir, is the slide visible, sir?
Yes, they are visible and you're audible also.
Thank you very much, sir. So good evening, sir. Good evening, Kabra, sir, and everyone. So I am Dr. Ahmed Subair. I am an interventional neurologist. I have trained from Bombay Breach Candy Hospital under Dr. Anil Karapurkar, sir, for intervention. So this is a case I wanted to present to you, which is a kind of a rare case.
Dr. Ahmed, could you speak up a little loudly, please, so that, you're more clearly audible? You could go close to the screen.
Sure, sir, sure. So this is an interesting case which came to us as a presentation of an acute stroke. And this was regarding a 58-year-old male who came with right hemiplegia, which occurred in the morning. It occurred like a wake-up stroke. On asking the history, they said that he had a right hemiparesis 1 week back, which improved on the same day, just like a transient ischemic attack. On probing further history, they had said that he had undergone some endovascular treatment for a large aneurysm from NIMHANS in 2019 and has been on antiplatelets since post-procedure, and non-case of coronary artery disease treated medically since 15 years. So with this history, and he had presented to us within a window period of 7 hours, considering it to be a wake-up stroke. And his weakness was right-sided, upper limb more than lower limb, with global aphasia amounting to an NIHS of 15 and MRS score of 5. So seeing this condition, his vitals were stable. There was no BP elevation. And on examination, we could find that right side was weak with global aphasia and facial deviation. And at this point, when such a patient comes to us, there are two things we usually think, whether it could be a bleed or an infarct. Bleed just because of the reason was that the patient was a case of a large aneurysm treated with endovascular treatment and has been on long-term antiplatelets. The factors like no elevation in BP, early morning appearance of the patient, that is as a wake-up stroke, would keep us in thought, keep in line that it could be a ischemic stroke also. So first step of this management definitely would be to go for a CT, just because that the patient had crossed the window period, and since even then we went for CT just because the reason that it could be bleed, and also that the patient was very restless because he had global aphasia. So if you can see the CT here, the CT showed left MCA region a large thrombosed aneurysm with some metal artifacts which we were not sure at that time whether it could be a coil or an aneurysm. But the picture at that point didn't seem to be like a coil. It seemed to be like a stent which was placed in the MCA. That is kind of a flow diversion done in 2019. And at this point, after the CT, and we couldn't find an obvious infarcts in that region. There was definite hypodensities over that region, but because of the artifacts, we couldn't clearly make out that region, if you can see. And there is hypodensities here in the left MCA superior division and inferior division, but further clarification couldn't be made. And this was the this stent, like the stent artifact due to metal is seen here. So further probing, they said that the patient had undergone a flow diversion from NIMHANS, and that was in place, and most likely that would have undergone thrombosis, that is stent thrombosis. Usually stent thrombosis occurs during the procedure or post-procedure, not this late, that is after 4 to 5 years. MRI not done just because of the reason patient was aphasic, restless, NHS was 15, lots of artifacts, and MRI also could make us clueless, or we won't be able to come to a conclusion with just an MRI. So since this, I was working in my hospital, which is intervention center. We went ahead and did a angiogram to see what was really happening. And if you see the right side, DSA showed that there was no much a problem there. MCA, ACA, and ICA were visible, and even the neck region was normal, no occlusion there. And his arch was not normal. He had an abnormal anatomy. It was a type 2 arch with common origin of the CCA from the same point. And also the left vertebral was directly arising from the arch as seen in the second picture. So there is direct origin of left VA from the arch. So we expected more of abnormal anatomy or tortuosity in this patient. And as expected, we found out that patient had a difficult access to the left CCA, for which we had changed the catheters and tried for the access. This was the angiogram done. The angiogram had shown in the left CCA. If you see here, we can clearly see that there is a occlusion at the just beyond after the bifurcation of ICA to MCA and ACA. So it was at the MCA stem, in fact, and this had occurred at the region where the previous stent was placed, which was done for a purpose of flow diversion of a large aneurysm. And further, if you see, there is MCA occlusion at the stem, and also where we had kept the catheters, there was vasospasm. So time was less for us to act in this situation. And so we went ahead with a guide catheter, microcatheter, and distal access catheter. And if you see carefully, you can see we had tried to pass the clot which was occurring, which had occurred within the stent. The spiral thing which we see there is actually the stent, and through which we try to negotiate the micro wire, which is a 014 wire across. And you can see how difficult the pushback of the wire in this case, which suggests that the clot was very hard. And through careful navigation, without damaging the stent, we penetrated. The one thing which I had in my mind during this procedure was that even though stent was there and there could be a space within which the microwire could perforate, since it is more than 5 years, there would have been adequate endothelialization of these stents. So it is not an issue, and there is less chance of a perforation if you do the procedure very carefully. So you can see that we had went across the thrombosed stent with the microwire and the microcatheter. And later that, after that, we had deployed the stent retriever. We used the solitaire 640 stent retriever. There is a high chance that the struts could get caught between the stent assets, the stent used for flow diversion. But we had done it very carefully so that we placed the stent retriever across the thrombosed Leo stent. And this was post-procedure. We had obtained a Tiki 3 flow. This was after the second pass. So there was complete opening of the vessel. So in this unsubtracted image, we can see the stent in situ, and this was the clot removed from the thrombosed Leo stent, which was used for flow diversion. So this was the pre and the post procedure. We can see the complete recanalization and total flow recovery to the superior and the inferior divisions. And post procedure, we had infused the patient, started the infusion of tirofiban, so that because the stent had thrombus, there was likely chance that there is a stenosis also associated, and there is a chance of repeated closing of the stent. So tirofiban infusion was started. Later, the patient was started on the ticagrelor, because we know clopidogrel Asian population there is a resistance, and in cases like stents which are made of chromium, nickel, etc., there is high chance for thrombosis and closing down of the stent, which had already had occurred in this patient, because the patient previously started on ticastro, that is ticagrelor. Some neurologist, he had done the procedure in NIMHANS. Because of COVID, he had lost follow-up, and he was following up with some neurologist here in this part. And that may be the reason they had stopped the ticagrelor without knowing the consequence. And some stents may need a long-term dual antiplatelet or a, antiplatelet therapy. So this patient was again restarted on ticastro. And so this was a case of aneurysm treated with flow diversion, which had closed down after a very long time, that is 5 years, which is a very rare occurrence. And for which we had done the thrombectomy with complete TICI-3 flow and success. So aneurysm is the abnormal dilatation, and this is the mechanism of flow diversion. We put a stent across, which drives away the flow from the aneurysm shrinks, but the patency of the vessels which is near to the aneurysm or where the stent is placed is regained, because the flow or pressure gradient is still present. Very many flow diverters are used. The most common I have done is with pipeline, the latest one being Vantage. I think in 2019 for small vessels, the only stent available was Leo for putting in the MCA. But now all the major companies have come up with small stents. So just to show you how a stent or a flow diversion is done. So you can see the aneurysm, saccular aneurysm, especially wide neck, large aneurysm, the coils won't stand. Even stent assistant coil may not help. So in such cases, we deploy the flow diverter across the neck of the aneurysm, and this helps to redirect the flow. And we can see that after about 6 weeks, endothelialization of this vessel start, and there is complete shrinkage of aneurysm by about 6 months to 1 year. We usually grade it through one scoring called OKM scoring, and we can see it slowly shrinks off. And this is the stent which was done for this patient, that is Leo stent. So this is a very different or unique case where there was a late thrombosis of the flow diverting construct, and late prior case reports have been of the stents or the flow diverters put in the posterior circulation aneurysms. So, and one thing, important thing, all the neurologists or the treating physicians should understand is that in case of such patients who has been put on flow diverters, we know the ideal time is actually a matter of debate. Using dual antiplatelets or DAPs in case of stroke. That is, we say that it should be at least 21 days, can extend up to 90 days based on the latest criteria. And but for flow diversion, the ideal time period for continuing antiplatelets is at least 18 to 36 months. And one of the reasons this patient had undergone thrombosis of the stent was most likely the reason that the antiplatelet therapy was changed and dose was reduced. So from this case, we could make out that we should understand the difference in antiplatelet usage or follow-up antiplatelets in case of flow diversion patients. And also keep in mind about the antiplatelet resistance. And preferably, the operator should treat the patients who has been treated with flow diversion. And also, we should be aware that the latest drugs, ticagrelor, are very good and have superior efficacy when compared to clopidogrel. And when you taper these drugs, always keep the patient in close confidence and close follow-up because there is a chance of late thrombosis, not very common, but even though we have to keep in mind. And also one more thing I wanted to make into notice that we in our country it's not an issue because we don't have more than 3 Tesla. We still rely on 1.5 Teslas. But when a patient on flow diversion is prudent always to do a MRI which is less than 3 Teslas. So this video I had taken in the morning. Today morning in the OPD, I asked the patient to come. So this was a patient who had right hemiplegia, global aphasia. Now he is able to tell his name. He is able to walk. He is able to squat and get up without any issues. And he is perfectly normal. Mild facial deviation is there. Other than that, no other issues at present. So after 3 months, so this was done in November. So after this today, I had taken this video. Now NHS, except for that facial deviation, get covered. So this was the case I wanted to bring notice to everyone, especially in neurologists treating patients on flow diverters, which is actually upcoming, because even the intrasaccular devices like contours, there are web devices, RTC, etc., also being used for aneurysm, which can also lead to thrombosis. So we have to keep abreast with the changes in neurointervention, which could lead to cases like this, where the patient presents with thrombosis due to inadequate platelet. So these are my teachers from Mumbai. Anil Karapurkar sir, he had taught me. He's considered the father of neurointervention in India. So he had taught me all these procedures. And my teachers, Fasal Ghafoor sir, Rafiq sir, and Krishna sir, and Mohammad Kunju sir. So with this, I like to end my talk here. So just a poem which I had written. So each clot tells us a unique story. Some has history, but some remains a mystery. But all of this teaches us to overcome this confusion or quandary. Reassured by the hundreds of smiles, saved by this timely deed, learning clot by clot and stroke by strokes, I am cleared of all my worries misconceived. Thank you. Thank you very much.
Very nice indeed. Dr. Sunil, welcome to the webinar. We are very happy to have you here. We have already introduced you in glowing terms. So, would you like to comment on this case?
Yes, the important thing is that the antiplatelet agents should be continued for a long time. They shouldn't be delayed, they shouldn't be stopped. And many people who are not knowing about the stent retrievers and the newer things, they tend to stop dual antiplatelet and only put on one antiplatelet. So thrombosis can occur through the stent, and this is exactly what has happened in this patient. The other thing is that dual antiplatelets, the rate of intracerebral hemorrhage is more, so one has to be very cautious. But when there is a definite indication like this that you have put in a stent, then it is better to err on the side of giving dual antiplatelet agents than trying to stop them after a few weeks or a few months. So that is one of
But
the...
this was 7 years, no?
Nearly 5
Sorry?
years.
How many years?
Nearly 5 years. 5 years.
5 years.
They
So
had
how long what is the recommendation? Dinesh, what do you think?
Would have given single.
And dual antiplatelet, for how long should you give? Doesn't
Just
it get
1.5.
re-epithelialized?
Yeah, it does get, and I would have stopped after 18 months or so.
yeah.
Then
So
that is exactly what this
Because
patient
to
does.
give dual antiplatelet for 5 years, I think is highly risky. Now
Yes.
this one has occurred. I do agree it has occurred, but general recommendation would not be to give it for so long. I mean, that is my view. What do you say, Dinesh?
Yeah, I agree with you.
You're right, sir. Actually, for this patient,
Yeah, Ahmed, what is the data? You showed a little, but can you just clarify it again for everyone?
sir, this is a special case where we had done a flow diverter.
Little loudly.
I didn't mean to say that we have to continue with dual antiplatelets. But even if you are starting on a dual antiplatelet, it's better to continue at least 18 months in case of a flow diverter. 18 months.
Yeah.
And by changing the antiplatelets, make sure that you don't drastically reduce the dose. That is, the patient was initially started on ticagrelol, that is a CYP inhibitor, and later by about 1 year or 2 year or so, they have changed it into just EcoSprint 150 or later into EcoSprint 75, thinking that patient had improved. So that is what had happened in this case. And my idea of putting up this case was to tell about the dual antiplatelet usage in flow diverters should be at least for 18 months. Then you can change it to a single antiplatelet. It's not to continue dual antiplatelets for 5 years, but at least for 18 and customize the patient accordingly rather than.
Why did you say 18 months? You said reepithelialization occurs within a few weeks to months, no? So
Yes, sir, but
then why so long? Why this 18-month period?
because in case of flow diverters, reepithelialization starts to occur at 6 months, sir. It may take time based on the porosity of the stent which we are using. So ideally, if you are planning to change the dual antiplatelet, we have to do a repeat digital subtraction angiography. Make sure there is no residual thrombus or residual aneurysm, and then we have to proceed with changing the antiplatelets rather than just blindly changing it to without doing a DSA. So always follow up DSA is a must in case of flow diversion done patients at least 1 year or later. And it is a routine practice.
Yeah, but now, okay, you do it at 1 year and you find that the flow is good. And then after 1 year, the aneurysm has also collapsed. And he's on DAPT. So then I think they did the right thing by reducing to aspirin. I mean, I don't think they did a wrong thing.
They didn't do a
And
DSA.
no, I don't think they did a wrong thing. So
they hadn't done
it
a
just
DSA for
happened.
the.
Maybe this chap, he continued to smoke, or he got dehydrated, or there may be some reason. I mean, which maybe you can clarify why this clot occurred there. So there can be another cause. I mean, in general, I would say that, okay, you do a check angio or the CT angio after 6-8 months, see that the flow is good, aneurysm has collapsed. And then maybe in a year or so, you can reduce it to single antiplatelet. At least that's what I've done. And I don't think we've had any problem. This is an unusual thing, but to continue for so long is highly risky for GI hemorrhage and brain hemorrhage and hemorrhage somewhere else, So it's just unfortunate that it happened. And it's unlikely that, there was resistance because, sometimes this EcoSprint doesn't get absorbed because it's gastro-resistant. That is the commonest cause of aspirin resistance. Either they are a defaulter or the thing doesn't get absorbed because the packing, the formulation is too tight. That is the commonest cause of aspirin resistance. It's not a chemical resistance, but it's because of the method of giving it.
I understand.
And
Sir.
one or two things I wanted to ask you. Dinesh, anything else you want to say? Dinesh, Sunil, anything else?
Yeah, I had a comment. Like if you had a advanced imaging at your facility, if you
Little
had
loudly,
done,
little loudly.
if there was advanced imaging at your center, if you had CT perfusion imaging, you could have given IV thrombolysis also in this case.
We can't hear you. We can't hear you.
Am I audible?
Yeah, now you are.
Okay. If there was advanced imaging available, you could have done perfusion imaging and could have given IV thrombolysis in this case also.
Advanced imaging is there, sir. One issue with this patient is the clot burden. That is the length of the clot is more than 2 to 3 millimeters. If you see this, 2 to 3 centimeters, I would say. And it's always an issue when we do thrombolysis. If the clot length is more than 8 millimeter, likely that the thrombolytic agent may not cross and it may not work. And for this specific case, I would say the window period was more than 7 hours. If you take it as a wake-up
No,
stroke.
this is not a case for thrombolysis. But Ahmad,
Say
why did
7
you
hours.
not do CT angio?
CT angio was not available at our center. We usually rely on MR angio for this patient, for any patients.
You
We
do
have
MR.
CT here.
You don't do CT. Okay. Another thing, you said we couldn't see the aspect, but if you can show that picture again, there is very clear this thing, at least what I glimpse that you showed. Just show that picture, please, again. Yeah, that other one, little higher, that higher picture. Can you enlarge it?
1 minute.
You see, the picture is not. You had another picture also, no?
Yes. This was a video here.
Video. Yeah. Now, if you see, wait. Now, if you see the salsa and gairai on the right side and on the left side, there is a distinct difference. I don't have a pointer. Can you see my pointer?
I'll show you.
No. Okay. So if you see the salsa and gairai on the right side and on the left side, there is a distinct difference. The gray-white differentiation on this side is very clear. On the right side is very clear. On the left side, it is blurred.
True, sir.
The basal ganglia on the left side, caudate nucleus head is well seen, not so well seen here. So actually, you can, you have to train yourself and train your eyes and brain to see the aspect score. And I think this aspect score is definitely more than 6. I mean, sorry, less than 6. You have a higher cut? Just show some more cuts.
The image quality is quite suboptimal for calculating aspects here.
Dinesh, what?
Imaging quality is quite suboptimal.
Yeah, so the differentiation on the two sides is clear. And
Yeah,
you
there
said
is, but
MRS is 5. You said MRS is 5. Now, what do you mean by MRS? In acute stroke, why do you want to see MRS?
Sir, patient was bedridden. I just wanted to compare it.
No, he was bedridden before the ictus or during the ictus?
During.
No. So MRS is a this thing for on follow-up. It's a disability thing. So for acute stroke, you see NIHSS, which you have done. MRS is to be done on follow-up.
Yes, sir.
And on follow-up, your MRS was one which is extremely creditable. And what you've done is excellent. I mean, I have absolutely no words to praise you for that.
Yes, sir.
And you could do it in 2 passes. And so what you have done is excellent. But there are these 1 or 2 points which we want to discuss. And you don't mind us discussing, I hope.
No, sir.
Yeah. So,
Dr. Ahmed, I have a question for you.
Yeah.
Why did you choose a solitaire and not an aspiration device here?
Sir, the clot was very hard. We went in with a CAT5, that is an aspiration catheter, and tried once, but no clot came in. So then we went ahead and crossed the clot. While crossing the clot, we could find out that it is a very hard clot. It's not an aspirable clot, as we had initially thought, because we thought it's an acute one. So it could be aspirated, but it was not. Even for aspiration, we had needed 2 passes. Even after doing a very good placement of the stent retriever, we needed 2 passes, which suggests the severity and hardness of the clot which occurred in that patient.
I have a question for all of you three. Is there any role of a single antiplatelet and an anticoagulant, newer anticoagulant?
For this patient, sir?
Yeah.
No role of anticoagulant.
We use anticoagulant based on the mechanism of stroke. If there is a cardioembolic or artery to artery embolism, this seems to be a direct thrombosis, which would work only with an antiplatelets, especially the newer ones, since the stent is in situ, that is ticagrelor.
Ahmed, what is this round blob? It's the aneurysm or it's the thrombus inside? What is that?
It is a thrombosed aneurysm which we see here.
Achha, it's a thrombosed aneurysm. So aneurysm didn't collapse. It got thrombosed.
Yeah, they haven't done a repeat DSA for this patient. Ideally, for all.
No, but when you did the DSA, it didn't fill up, no? So it was thrombosed.
It was thrombosed.
Yeah, because on your DSA, it never filled up.
Yes, sir, true.
So this is a thrombose. Usually, it doesn't thrombose, no? What happens? It shrinks or it thromboses? What happens?
Small aneurysm usually shrinks, sir, but a larger one usually gets thrombosed and reduces in size. But
It may have been thrombosed even before the flow diverter.
Yes, sir. Maybe at the same time.
Maybe, we don't know.
Yes, sir. And I had seen this cortical medullary differentiation in this patient, cortical differentiation, subcortical differentiation, but couldn't make out further what is happening with the CT. That's why, without going for an MRI, directly went for
No, there's no need. Why do you need to do an MRI? Why do you need to do an MRI? You don't need to do an MRI. You're wasting so much time, no?
True, sir. True, sir.
You don't need to. This is good enough. This
Yes,
has
sir.
shown that there is no hemorrhage. Person has an NIHS of 15. He's
Yes.
hemiplegic and aphasic.
Yes, sir.
You don't need to see the infarct. You don't need to see. There is a clear mismatch between clinical and radiological.
Yes,
And
sir.
there is no
Mostly this is
hemorrhage and there's no contraindication.
Mostly this is a wake-up stroke.
Yes, sir. Wake up stroke. That's why usually
No,
we go for
even
diffusion.
then, see, it is door to home to door time was 7 hours, you said, no?
7 hours. Yeah,
Yeah,
but
so there's no
from the
question of
time
giving
he,
IVT.
Yes,
from the
sir.
time he went to sleep is 7 hours. It's
Yes.
a wake-up stroke. So from the time he went to sleep, it is 7 hours.
Yeah.
Yes, sir.
So it is a potential patient for IVT.
No, we are not thinking of IVT by any chance.
Why?
This is not a case for IVT.
Why? What? Why?
So I think sir has a valid point. It could be a case of IVT if we have a proper flare diffusion mismatch.
Yeah.
On the
Or
wake
if
up.
you have a perfusion imaging, if you
But
can
you said
document
7 hours, no? I didn't get that. Was it 7
From
hours
the-
or was it wake up?
Wake up in the sense that last seen awake with normal. If you take, then the wake up period would be
He came
7.
at what time?
Early morning, sir. Early morning, 6, 7 or something, sir.
So you should take the midpoint or you should take the last seen normal?
Last seen normal, sir.
last seen normal.
Okay, so last seen normal was when?
Roughly correspondingly, sir. I think he works
7
at
hours.
shop, came back at 10 or 11, and then he had slept.
10 or 11, and then he came at about 6,
That
7.
is the point where MRI comes into picture, where medical legally also, to suggest if thrombolysis is not needed or not. But we
Yeah,
didn't
but
go
with
ahead.
such a large clot, it's not going to work. Yeah.
True, sir. And aphasic patient, to keep the patient still in the MRI for 20 to 30 minutes is impossible unless we intubate and sedate the patient, which is not at, I didn't find it prudent to go ahead at that time. Rather than, I thought the same floor we have the cath lab, we'll see what is happening.
Yeah, I think you've done well for that. I
Very nice.
wouldn't push too hard for MRI. You don't know whether that thing is compatible, not compatible, what.
All the flow diverters are compatible for
Yeah.
1.5 Tesla, sir, except
Yeah.
for
So
small
which
one.
MRI did you have?
1.5.
You had
We have
1.5.
a resource limited setting, I would say. Our CT with the clarity is less because it's a 16 slice CT, which is, I would say, not enough.
16 also, you can do a CT angio. Huh?
True, but we don't have that software here for 16. So we are upgrading few months.
Okay, no problem. You have to make do with whatever you have.
Yes, sir.
With that also, you have done well.
Thank you.
Everyone cannot have everything.
Yes, sir.
Very nice case, Dr. Ahmed. Very nicely done. Thank you.
Very nice, very nice. Congratulations.
Thank you very much,
And
sir.
patient will be very happy with you. And
Yeah.
I'm sure he'll send you biryani on whenever you want.
Yes, sir. Very nice.
Okay, thanks. Yeah.
Thank you, sir.
Yeah. Sunil, can you take it over now?
Yeah, yes. Can we have the next case, please? I think Dr. Aswati Sasidharan.
Yes, sir. So this is the screen is visible, sir.
Yes, visible and
I'm audible.
audible.
Yeah. Good evening, all. Much privileged to present a talk in this platform with these eminent chairperson and moderators. So I'll start off my talk. This is
We can't see you.
so there is a small issue. The thing in which I'm presenting is not, camera is not working, but I have another one where my video is on.
Okay, go ahead.
Simultaneously, both are going on.
Okay.
Yeah.
It's nice to see.
We can see you. We can see you.
That's in a different device, sir. Both are recording
Okay,
together.
okay,
The
okay,
one has
whatever it
some
is,
issue
come.
with his camera.
Okay, go ahead,
Okay, so
Swati.
this is a series on Wernicke-Komischer syndrome. I'm Dr. Ashwati Shashidharan. I'm working in MES Medical College, Perindalmanna, Kerala. So, coming to introduction, this Wernicke-Komischer syndrome is a mesencephalic vascular syndrome. It's a relatively rare syndrome which selectively affects the Wernicke-Komischer. This is characterized by signs like bilateral cerebellar findings, internuclear ophthalmoplegia, and delayed onset palatal myoclonus. This was initially described by Lermit, and it was named after a German anatomist, Wernicke, who described it as a horseshoe-shaped commissure. This Wernicke commissure refers to decussation of superior cerebellar peduncles, brachium conjunctivum, in the midbrain before their entrance into the red nucleus. So we have some important structures nearby this commissure, which are MLF and inferior olivary nucleus and brachium conjunctivum. Accordingly, we have the clinical features also. If MLF is involved, we will have eye findings like skew deviation, nystagmus, ocular tilt reaction. And when this olivary nucleus is involved, it will go for a delayed degeneration. So when that time you will have a delayed palatal tremor because of the circuit destruction in the olivary nucleus. They'll have a disinhibition of the olivary nuclear signal and it will go for a hypertrophy and then likely a delayed palatal tremor, which we usually don't see in an acute case. And then the brachium conjunctivum, which causes the bilateral cerebellar signs. And according to the artery which is affected, our imaging will show diverse morphology like an oval lesion. It could be a oblong, it could be a round or V-shaped lesion like a heart lesion. Varied presentations are seen in MRI. And so the oval and round lesion sparing the ventral midbrain is thought to be due to the involvement of the paramedian perforating arteries. Usually this is supplied by interpeduncular perforating arteries, which can either branch off from the basilar or the proximal PCA before giving off the PCOM or from the superior cerebellar artery. Any three of these are possible. So accordingly, we'll have the imaging finding in the MRI. So we have a proposed diagnostic criteria which is put forward by Sheetala et al., where you have the essential criteria and supportive criteria. Essential criteria includes ipsilateral INO, unilateral or bilateral ataxia, and neuroradiological evidence of caudal midbrain involvement. It's also possible to have a bilateral INO as well. And the supportive criteria includes rubral tremor and very, very rarely palatal myoclonus, so palatal tremor. So this diagnosis may be established with the presence of all the essential criteria with or without one or both of the supportive criteria. So now going to the case witness, we have 4 cases. The first one is a 67-year-old female who is a hypertensive and has history of CAD. She presented with acute onset diplopia and unsteadiness. On examination, she had bilateral INO, bilateral cerebellar signs, and wide-based ataxic gait. So there was a diffusion restriction in the paramedian area. Here you can see there is a heart-shaped lesion. It's a heart sign in the midbrain. The next one was a 40-year-old male, hypertensive, stroke on antiplatelets. He had double vision for 1 day and unsteadiness for the past 3 days. And he presented on the day 3 of symptom. He had bilateral INO and bilateral cerebellar signs. And imaging showed an acute infarct in the caudal mesencephalon. The next case was a 57-year-old male, diabetic hypertensive, case of CAD with old stroke. He had headache and vomiting, followed by unsteadiness of gait and diplopia. On examination, bilateral INO, bilateral upper limb incoordination, and imaging showed an acute infarct in the midbrain. MRA showed a deceased. And the last one was a 42-year-old male who's a hypertensive, presented with acute onset diplopia and unsteadiness of gait. On examination, he had bilateral INO with impaired bilateral, there was bilateral cerebellar signs and gait ataxia. Imaging showed an infarct in the caudal mind. That was also solution. So now this presentation is all about these brainstem. Hello, am I audible?
Yes.
Yes, you
Yeah.
are audible.
Yeah.
The presentation is all about the cases involving the midbrain, that to a caudal midbrain. Some take up the very special shape of a heart or even a paramedian infarct for that matter of any shape. So why is shoe shape so much important, and why had we taken up this case for discussion is that this area of occurrence, especially the symptoms which this acute ischemic stroke present with, is a sort of different from the rather usual symptoms of brainstem strokes. All are very familiar with the name syndromes like Weber, Claude, Benedict, and all. But this entity like Wernicke commissure is less spoken of, and it is a rare midbrain stroke which is less discussed. So this presentation is basically to put just to unveil the fact of the existence of a very rare midbrain syndrome. And in the last 2 years, we have got these 4 cases. And another thing which is so much important is we usually miss this balance and eye part in the mnemonic, even though it is very widely we are doing campaigns on stroke awareness and all. The balance eye part has not gone too much into the public. So we have to stress a bit more on the brainstem signs like the ataxia and eye signs while giving awareness to the public. And when it comes to the awareness for the physicians, like this periaqueductal gray is a part which even normally enhances. So we have to correlate the clinical findings and the imaging very prudently so that we are not missing hyperintensity in the periaqueductal gray, which might be normally seen also. And all these patients, we couldn't get them within the window period. It might be because of the fact that this is not easily picked up by the layman, or the general population has a less awareness about the brainstem signs, which they should which should alarm them more than like they might think of it might resolve in a few hours or thing. It's just a vertigo and all. So I would like to emphasize these 2 points. And that is the main crux of we selecting these 4 cases for this presentation. Thank you so much.
Yes, Dr. Dinesh.
Yeah, very interesting cases. What is the stroke mechanism in these cases?
Probably all of them are lacunar, sir. All those are interpedunclar perforating arteries. So we would think more in terms of a lacunar stroke, which is happening.
But these could be cardioembolic also.
Sure, definitely.
Dr. Dr. These
Ashwini.
perforating vessels, usually they don't cross the midline, no, as far as I remember.
Yeah, they're not crossing the midline. On either sides, they are giving off branches.
So
But if it is
paramedian
arising,
on both sides symmetrical.
then we should think of an embolic mechanism as well. If it is taken off from the basilar.
Yeah, no, but how was the basilar artery?
In one case, we had a diseased basilar, but the rest of the 3 had a normal basilar.
Okay.
But the interesting fact is that we had a heart-shaped lesion in the case which the basilar was normal.
Yeah. Did you look for rubral tremor? Not rubral. Did you look for palatal myoclonus later on?
Palatal. We looked for palatal myoclonus in all the 4 patients, but as we expected, we couldn't find any palatal tremor.
Yeah, but it depends when you see, palatal myoclonus may take time to occur because there is hypertrophy, degenerative hypertrophy of the olivary nucleus. So
It
that
might
takes
take
time.
time. Yeah, it time.
Yeah. So,
I
if
follow
you
up
if you look
also.
for it
We
acutely,
have,
if you look for it
they
acutely, you won't
are
find
all
it.
Definitely, sir.
So
All
maybe
of them
on
are
follow
on
up after
follow-up.
few weeks, months, you can see it.
Definitely, sir. All of them are on follow-up. We are definitely watching on the palatal tremor. I
Yeah.
like to, we are recording all these 4 cases.
Yeah. Very interesting, I must say.
Thank you, sir.
Dr. Sunil?
Yes, extremely interesting. I have not seen such patients before. Really, I mean, maybe I have missed them. But the mechanism of the stroke is, I mean, I don't know what is the mechanism of the stroke. It could be embolic. It could be, I don't know, from a artery of aorta up or artery to artery or left ventricle, left atrium up. I really don't know the mechanism of action.
You know, my mentors used to always tell us that unilateral INO is vascular or MS, and bilateral is always MS. But now here you have shown that bilateral INO can also be vascular. So
Yes,
as usual, there are exceptions to all thumb rules. And this is an important exception. I mean, we also teach that unilateral INO is usually vascular, but could be MS. But bilateral is almost always MS. But now here you have shown, which I'm very happy to see, that even bilateral INO
vascular.
can be vascular. And these patients had ataxia, limb ataxia.
Yeah, all of them had ataxia, and 2 of them had bilateral ataxia. 2 of them had bilateral ataxia. All of them had limb ataxia.
Limb ataxia. And rubral tremor.
No, none of them had rubral tremor.
So this occurs just proximal to its entry into the red nucleus. Is that correct?
Yes, sir. Very correct. It's just proximal to the entry of the
Just
red
proximal
nucleus.
to the entry, no?
Yeah. Probably that is why that is untouched. The red nucleus part is and no rubral tremor.
So maybe that's why rubral tremor was, but in the described literature, rubral tremor is there.
And it's one it could be possible.
Okay, well, have you
Yeah,
published? Have you published this?
Already the literature has a series with 8 cases. So we are looking forward for more cases so that it will cross the number
you
8.
don't have to compete with number of cases, but
No.
what you
Actually,
have to
this was
show is,
published from the
because it's
institute.
unusual. I think you should show it.
Very unusual. Very unusual.
Yeah.
This was published from the institute from where I did my DM. So, they were asking me just to count on more and just cross the number so that that would be much more relevant. That's all. Anyways, we are planning to publish, and my associate professor there had proposed this criteria as well.
Yeah, Dinesh?
Very interesting cases. I'm enjoying everything that
Thank
the
you so
young
much.
neurologist is telling me.
Yeah.
But
Thank you.
my gut feeling is that some of these could be cardioembolic. In arterioperitoneal infarct, most of them are cardioembolic. That is the most important etiology. And these
Yes, sir.
arteries are very, very near the top of basilar. So look at the cardioembolic source, do Holter monitoring, and you might find something else.
We have done, sir. Holter was done for all, especially
Yeah.
2 of them were recurrent strokes. So Holter was done for all.
Yeah, and
But
some of them can.
It was not a loop halter. It was just a single day halter. We might have missed it, but in a single day halter was normal for all 4 of them.
Then you can't find the cause. That's fine.
We need more cases, more time for Holter, at least a week of Holter monitoring before we can say
true.
it doesn't seem to be cardioembolic.
Even
But,
then, some are saying 6 months. Some are saying, I mean, it just goes, it's endless.
Lifelong or something like that.
So we don't know. Yeah.
Wonderful cases.
Yeah, good, great.
Okay, sir.
Do we have any more comments?
Thanks to all the
Dinesh?
speakers.
Dinesh?
Thank you very much. Enjoyed.
Thank you, sir.
Yeah.
Thank you, sir.
Sunil, anything more?
No, I don't think so. I mean, I had some problems in getting the connection, but I did have eventually managed to join.
Yeah. You came little late.
I missed a little part of the first
Yeah,
case.
okay.
Whatever it is, they are beautiful cases.
But as usual, we've had a lovely 1 hour. And as I promised you, we will definitely learn something. Every time I'm here, I learn something. So I thank both of you, Dr. Aswati
Shruti.
and Dr. Ahmad. You all are working in the same hospital?
Yeah, both of us are working in same
Oh,
hospital.
great. And I was just seeing that your place is what is it called? It's the Center of Medical Excellence in Kerala. Is that correct?
In a way,
But it looks like that from whatever you all have presented. It looks as if it is at the pinnacle of stroke neurology in at least in Kerala, maybe in the rest of India also. But we are very, very happy to have both of y'all. And we've learned quite a few things. And we've clarified things in our mind also. And so I hope we become better stroke neurologists for the future. As Ahmad said, you learn stroke by stroke. And what else did you say? By clot by clot.
Clot by clot.
Next time, Ahmad, you send that clot for histopath.
yes, sir. Yes, sir.
You send that clot for histopath and see whether it's a red clot, white clot, more platelet, just for fun. Nothing that we are going to do. But, it's very interesting, because the clot sometimes, well, one part of it is red, one part of it is white, one is platelet rich, one part is platelet rich. So it's not a uniform clot like that. And even the colors that you showed, they are not uniform.
Yes, sir. True.
And next time you show those clots, put one scale there so that, we get to know the size. Because here, just like that, we can't make out the size exactly of the clot.
Yes,
So all the clots, henceforth you send for histopath.
Sure, sir.
And you'll be surprised what you find.
True, sir.
You'll be surprised what you find, So, and even the pathologists, they've rarely studied all these clots, So if somebody can, and if you have these big clots with all this empty going on, I think we can get quite a lot of new knowledge also. So maybe you can start that. Dr. Namra,
Yes, sir.
could you
Sure.
take over? I think we've done for the day, and we are exactly on time, 9:29. So I think we've done excellently as far as time, as far as content, and as far as discussion is concerned. Namra.
Right, sir. So there's a comment
Yeah.
in the chat box. So Dr. Girish Vadgaonkar, he is asking if we should thrombolize such patients, as I only have CT brain available. Maybe this is relevant to the first case which Dr. Ahmed presented.
Beyond window period, I don't think we can place any patients.
Yeah, Girish Vadgaonkar is a very active thrombolizer from
He's from
near
Parawa,
Jalgaon.
60 kilometers from where.
Yeah. So he's very, he's in a small hospital, but he's doing thrombolysis and he's very active and he's very keen to learn thrombolysis. Of course, in that small taluka place, he can only do IBT. But I think he's doing a great job and he's made some very good educational videos on stroke and stroke treatment. So as Ahmad said, this case is not a case for IBT. First of all, it's late. First of all, it's it's a M1 or distal ICA occlusion. So it's not a good case for IBT. I think direct MT is the way to go for this one.
So I think sir's question was that whether we can thrombolize a patient in a wake-up situation with just a CT in front.
Okay, answer that question.
I would like to say that even if you are like all the trials show that all the trials have come up with, that is evidence-based medicine shows that it is not prudent to thrombolize a patient just based on a CT, especially in the wake-up stroke. we at least need to have a diffusion flare mismatch with an MRI. That is what the theory and evidence base says. From my clinical experience, before thrombolysis, what I do is that always look into the SW image or the T2 gradient image just to see whether the patient is having any microbleeds. Because if you are beyond the window period, even if you want to thrombolyze the patient out of the box, like beyond the guidelines, just see the SW image. Because every patient window period strokes may be having an early morning stroke. Early morning, maybe it's not like a last seen normal, maybe early morning stroke also. But if you think the patient would benefit from thrombolysis, and if you want to do out of the box, out of the guidelines thrombolysis, always have a MRI in front. Always look into the diffusion flare mismatch. But even then, if you want to go ahead, at least see the SW image because the microbleeds would tell us whether to thrombolyze or not. If you see more bright microbleeds size and all, better not to thrombolyze because they are likely to bleed and cause complications. So that is my personal input for that, apart from the guidelines of needing a MRI in case of an acute stroke in wake-up period.
If you have,
How many microbleeds?
Sir, I'm telling like usually we say 10 microbleeds.
Yeah.
That's what we say, but it's not about the numbers. I usually felt the size, the location. If the microbleed is near to our infarcted area, then
I wouldn't go so far as to say that. You know what the recommendation is, that if it is more than 10 microbleeds in a previous MRI, then you give IVT with caution. It's not an absolute contraindication. And that is more than 10. If it is less than 10, if it is 5, you can go ahead.
the question regarding beyond window
we shouldn't worry too much about it. We shouldn't worry too much.
Beyond window
Only
period.
thing is, for wake-up stroke, we would prefer an MRI. There's no doubt. Now there are these new things that, beyond 4.5 hours, you can give IV thrombolysis if certain criteria on perfusion scan are met. That means infarct size less than 70, the mismatch more than 1.2, things like that. But, I find that very difficult to do in a peripheral setup. I mean, very, very few people are able to do perfusion scan, and that to automated perfusion scan using AI. I've had a lot of problems with this AI. And, I'm not at all comfortable with it. And now we stopped doing it also. Because, many times we get very, very wrong things and we get misled. At least I've got misled. So definitely wake-up stroke, we would like to do a MRI, no doubt about that. And if you see a consistent mismatch in DWI and flare, that means you should see nothing on flare. Nothing on flare. Then that is called a mismatch. And you should see it on DWI and nothing on flare. Then you probably, the infarct is less than 4.5 or 5 hours, and then you can give IVT.
But what if you see a few dots on the flare?
What?
If you see a few dots on the flare, then what do you do?
I wouldn't worry about that.
Because I do thrombolyze such patients.
I wouldn't worry too much about that. Because this MRI, it always overdiagnoses this thing. And for many times, people who rely on MRI, the thrombolysis rates are much lower because of this little confusion, Because of this little confusion. It is a hemorrhage. It is not a dot, which is a contraindication. Small little dot here and there, I don't think it bleeds. I mean, we are all worried about bleed, we are all worried. All of us are worried about bleeds. So we are not being foolhardy, we are not being rash. But I think little overestimation does occur. And you're not supposed to see a hemorrhage on CT scan, which is a contraindication. But MRI, small little thing here and there, I wouldn't worry too much. I don't know. Dinesh, what do you think?
Yeah, see, very interesting. This two trials, extend trial and trace 3 trial, what it has shown that the chance of bleeding even in extended time window of thrombolysis is very less.
Yeah, very
Even
less.
even if you thrombolize it in the trace 3 trial, the median time to thrombolysis is 12 hours and the bleed is less than 5%.
Bleeding was not a major issue.
The
So
issue is not much of bleeding. The issue is that the vessel may not open up, and then
And that's a
you.
different story. We are talking of bleed.
Okay, yeah,
So
yeah, it's not much of a problem.
everyone's worried about bleed, but I don't think we should worry too much. I mean, we are concerned. We are not, as I said, we are not foolhardy. We are not foolish.
the problem is that if you don't select the patient properly after 4.5 hours, the chances of getting a benefit from IV thrombolysis really goes down. So that's the problem. Problem is not that much of a bleed, and subsequent studies would show that. If you can do perfusion imaging, some sort of perfusion imaging, that's a good way to go. But then, as Dr. Ichapuri said, it is very difficult to do actually.
Not easy.
I don't know whether do you have it at Nagpur perfusion imaging.
Yeah, we do MRI perfusion imaging. We do ASL images and we do thrombolyze beyond 4.5 hours. Many of our patients don't afford mechanical thrombectomy, so we thrombolyzed in late time window by doing perfusion imaging and we thrombolyze. And some of them have improved.
Yeah, I think I would fully agree with that, Dinesh. Yeah, Namra, I think we are done. Namra?
Yeah.
Okay. Yes, sir, I'm here. Thank you so much, sir, for providing time for this meeting. The session was really exciting and fruitful. I'm sure the audience might have benefited a lot. Thank you so much, Dr. Sunil Gajre, sir, and Dr. Dinesh Kabra, sir, for the insightful discussion and your inputs. They were really helpful. Also, our eminent speakers, Dr. Aswathi and Dr. Ahmed Subir. Thank you so much for the wonderful case presentations. So today we are live with around 342 attendees.
How much?
344.
340.
Oh,
That's a
that's
good
lot.
number.
But
So,
then,
Ahmed, you've become famous in 345 people, huh?
Thank you.
but, the participant number is only 10.
No. Namra, Dr.
No,
Gajre
others are
says
on the
it's
link,
only
sir.
10.
No, there's a separate
Uh,
delegate link. So the doctors have logged in. This is only for the faculty, sir.
Okay. Okay, so
Don't
the
give us
faculty.
shocks, Sunil.
Yeah.
We are crossing 350, 400 regularly here.
Oh, great.
How much do we cross, Namra? You say, Baba. I don't want to say anything.
Definitely, sir. Your presence and the presence of eminent speakers and wonderful moderators, which we have for every session, we definitely close 350 every time for every workshop.
Mhm. And Namra is from which institute?
No, she's from Emcure.
She's from Emcure.
Okay. Good night, everyone.
Okay, good night. Bye.
Good
Good
night.
night.
Good night. कसं होतं चांगलं होतं cases.